It is now my pleasure to introduce our speaker today, Dave Hood. Dave, I'll hand it over to you.
Great. Well, thank you, Lesha, and welcome everybody as we do our fourth and final emergency preparedness webinar for the coalitions of Region 3. And today we're going to focus on training, testing, and then we'll talk a little bit about some of the recent feedback and survey information regarding e-tags. And that will kind of roll us through. So a quick refresher, when CMS came out with their emergency preparedness requirements, although there was a great deal of prescriptive items and all sorts of detail, that there were really 4 focus areas. And these are the 4 focus areas that we've talked about through the last 3 webinars, and we'll finish up today. We talked about the annual risk assessment, the hazard vulnerability analysis, and the importance of using that in preparing and developing your emergency preparedness plan. We will talk further today about how that should be used in reflection of training and testing materials and concepts. There was a session that we did on policies and procedures, again with particular focus on things that were prescriptively required by CMS, and then what your hazard vulnerability analysis, or HVA, was telling you. We spoke some about communications plans, particularly the who, the how, and the when. And again, as I mentioned, today we'll wrap up really focusing on training and testing. So let's start with the training concept. And when we talk about training, in my mind, the 3 questions that arise are kind of who, when, and what. So let's take a moment and go through those 3 items. So first off, it used to be that the training requirements in emergency preparedness were really focused on new employees. And that has now changed. CMS is fairly prescriptive in saying that initial training needs to be provided for new employees, and there needs to be training for existing staff members also. In addition to that, if you have folks that are providing services under an agreement, an example might be contracted nursing staff or a contracted medical director or anything of that sort, if those individuals are working under your auspices and under your roof, supporting your organization, then you also have the responsibility to provide training to them also. And then the last piece I'll add is that volunteers now fall into that fold of training. If there's an assumption that you would be using certain volunteers during a disaster, then those volunteers also need to be provided training, again, under the auspices of your organization. So with that being said, Lesha, this would be a good time for our first poll question to kind of kick things off and get a sense of what we're doing here. So the poll question is, who do you incorporate in your organization's emergency preparedness education? And in this particular case, you can choose more than one, but it'd be interesting to kind of get a vibe on what we're doing and what the group is doing. And so it's great to see that everybody joining us today is doing all of their employees. You can see that there's a little bit of a gap with the contracted staff and with the volunteers. So I would offer that as a takeaway from this conversation today, to take a look at what you're doing with those groups. The contracted staff should be an automatic. The volunteers may be an assessment of whether or not you would expect that they could have a role in your organization during a disaster. So thanks for doing that. So the second question then is when, and that's pretty easy. CMS says that the training must be provided at least annually, and that it must be documented. And again, the onus is on you to provide that documentation and maintain that documentation. And then the last piece here is, what are we really training on? And so the good news here is that CMS is not overly prescriptive. They're not prescriptive on what the topics could be. They are not prescriptive on the mechanism. You, for example, might decide to do some face-to-face, maybe more traditional in-service training. That's fine. You might decide that you're going to use some sort of web-based training module to get to the folks that you need to provide training to, and that's okay also. So again, how you do it is up to you, but you do want to make sure that it's documented. So what I'd like to do is take a couple of minutes and talk about what are some of the things that it may make sense to include in your training programs. So I suspect that most of you, particularly in Florida, have probably a fairly robust emergency plan, emergency operations plan, emergency management plan, whatever you're calling it these days. And as such, there's probably one of the first sections in that plan, and I know this is something we've talked about in a previous webinar, talks about what happens when there's a disaster. What is the protocols that we follow? Is there a code word that lets everybody know what's going on? Do we establish a command center on site? And if so, who goes to it? And what do other staff do? Should they report somewhere? Do they go back to the normal work areas? Where do you find the emergency manual? Things like that, that somehow everybody has to know when there's a disaster or a pending disaster, what do I do? To me, it makes sense that that might be one of the first things that we would cover, or that you might cover, in your general staff education. That providing clarity on whether it's an immediate disaster or you've been made aware of a disaster that might be happening in the future, what do we do and how do we respond? So that would be piece number one. Piece number two is sometimes these manuals or these plans, whether they're hard copy or electronic, again, they can be fairly robust. And sometimes half the battle or half the challenge is just trying to find the piece of information that you need at the time. And so I like to offer that sometimes a good, effective component in training is just going through the table of contents and providing some training on how to get to the information that you need. So if you need information regarding a particular disaster type, a tornado watch or warning, how do you get to that? If you need information in your plan about how to shut off utilities in the middle of a disaster, or you need your emergency menu, where do you find that and how do you access that information? Those are things that can be helpful and applicable to everybody, this concept of accessing key information and how do we get to it. And then the last piece would be some disasters you can look up. In fact, I would offer that the majority of disasters provide an opportunity to pull out your manual and review staff actions. However, there are a handful that you need to know the immediate response actions of right away. You don't have time to look those things up. Probably the best example of that is your fire procedures. So during a fire, we don't have time to go pull out the manual and look up RACE or whatever your particular fire procedure acronym and actions may be. Hence why there's constant training on those. We run fire drills. Your organization may have some cheaters on their name tags or some different things. We do a lot of things to make people aware of that, what they need to do so they can react instantaneously. There are a handful of other things that would be true for also. One example might be, and unfortunately, but true, situations of violence inside your building or on your campus, maybe to an extreme, an active shooter situation. 15 years ago, even 10 years ago, we weren't even writing those procedures. I suspect that you all either have one or have been thinking about putting one together. And those actions are things that you don't really have time to look up. There's some key actions in those procedures, some key best practices that all staff really need to know what to do. Maybe some parts of the country that might also be true for things like earthquake or things that just happen instantaneously that you have to react to quickly. So those types of things might be good topics to include in general staff education applicable to everybody. Some of you on our call today may be in larger, complex buildings, possibly multiple-story buildings, and as such, you may have intricate full building evacuation plans. And you may also have some specialized equipment should you have to vertically evacuate your building. And so if you have some of that, it would make sense that that might be included in your annual training. It might be included for everybody, or it might be included for specific personnel that would have the responsibility to gather and utilize that equipment if, in fact, we had to put it into play. So again, something to think about depending on your building and your organization, but trying to mitigate having to train on that equipment at the time of the disaster using the annual education to provide some review of it in advance. The incident command system is also something that I would offer may make some sense to do some training on. And generally, the difficulty is this, particularly in nursing homes and maybe other inpatient, outpatient healthcare facilities that just don't really use incident command that frequently and are not as familiar with the terminology. And that can be true for hospitals too, but I think hospitals are generally a tad more attuned to it over the years. But the concept is that we have to be able to speak the terms and the concepts of incident command so that we can really properly communicate in large regional disasters with our local, state, maybe even federal resources that may be supporting us. So if you get this phone call from a regional command center saying, I need to speak to your PIO right now so we can put together some messaging, we need to know, okay, they really mean the public information officer, and who does that role in my organization. So again, through the training concept, it makes some sense to roll some of that out. Hospitals have had for many years now what's called HICS, the Hospital Incident Command System, which is an incident command system based on the National Incident Management System, but is tailored to hospitals. Nursing homes have a similar tool that's a little bit newer, but as effective, called NICS. And again, if you go online and search HICS or search NICS, you can pull off the whole arrangement of incident command system tools. And then you can train on those tools, train on the job action sheets, train on the pre-messaging, train on all the aspects, train on the reporting structure, and things of that sort. Both HICS and NICS provide some training tools for you. Another option could be, and some of you may have done this in the past, is that you can go online through FEMA and you can take National Incident Management System courses. There's a variety of them, and a couple of them are actually tailored towards healthcare. And in those cases, you'll even receive a certificate at the completion of the course after taking a little competency quiz. So again, I would offer that this might be one of those components that makes sense for maybe all or some of your folks, your employees and team members, to receive some training on, to be part of your training components each year. So with that being said, Lesha, why don't you bring up our second poll question, because I'm somewhat interested in what folks on the call are doing today. So the question is, does your organization's emergency training curriculum include one or more of the following? And again, you can choose multiple answers here. So the options are, your disaster activation protocols, incident command, information on communications. I put that on here since that's such a focal point, and then overview of certain specific disasters. And how great to see that everybody that responded to that is doing all of those things within some part of your education. That is wonderful, and it doesn't surprise me in Florida. I'm sure if I asked that in other parts of the country, that might not be as accurate. So thank you for answering that, and kudos to everybody for including all of those items. So I'll mention to you that CMS has developed, and you may already know this, interpretive guidelines, particularly speaking to surveyors on what they should be looking for or the questions that they should be asking during a survey. And I pull up these 3 items in particular because I want to make sure that you're ready to be able to respond to these 3 items. So the first is you should expect that the survey team is going to ask to see what you have put together for your training curriculum and be able to show what that is. Secondly, it is not unusual that surveyors may ask some staff members how they would respond to a disaster. That's fairly common oftentimes with fire procedures. They may ask a staff member, what would you do if there was a fire right now? And they're looking for some sort of response about the crucial actions or rates or whatever acronym you might use. This is a similar concept. It's not putting the staff member on the spot to explain in detail how they're going to address any particular situation, but it's being able to provide a response that, during a disaster, these types of page announcements are made. I usually go back to my normal work area. Certain people go to a command center. Again, kind of those general activation protocols that that all staff hopefully are educated in and then can be able to regurgitate if asked. And then finally, we've seen this already only through the first few months of survey, but in some cases, survey teams are asking to go through employee training files to ensure that there is proper documentation relative to them receiving annual training. So again, those are 3 things that come right out of the interpretive guidelines, and I offer to you to be thinking about those and making sure that you're prepared in case you have to respond to any of those. So as we flip the topic now, let's now start talking a little bit about drills and exercises. And so historically, we were all required to run 2 disaster exercises annually. And that's still somewhat true. However, there's some pretty specific requirements around those. So now, one of those exercises has to be considered a full-scale exercise that is community-based. So that really means a couple of things. It means, one, that your facility has to physically be doing something as part of that exercise. Sometimes we call it boots on the ground. And then secondly, it has to be involving other community partners, whether it's your Office of Emergency Management, which is a good place to start. It might involve the fire service, emergency medical service, maybe the police department. It doesn't necessarily have to be all of them, but it needs to show that there's some collaboration with those groups. And as you have, I'm sure, heard us say through all of these webinars so far, there is just a massive focus on collaboration. And this is one of those checkboxes, being able to show that you, in fact, were collaborating with your community partners as part of at least one exercise annually. You then are required to run a second exercise. That one could be a couple of things. It could be another, what I'll call functional exercise, where you're physically doing something. Maybe you're running through a missing patient or a missing resident exercise or a loss of a utility, but that people are still doing something. Or if you choose, CMS is now allowing that second exercise to be what they call a tabletop exercise. So rather than boots on the ground and physically doing something, we can be in a conference room, we can be reviewing the procedures, talking about the roles and responsibilities and how we would manage a particular disaster. So that has actually gotten less restrictive in the fact that you can now run a tabletop for your second exercise or one of your exercises annually. So that being said, Lesha, let's bring up our third poll question as we kind of dig further into exercises. And really this is just for my curiosity's sake. I'd like to know, have you been successful in engaging your local Office of Emergency Management or maybe other community stakeholders in participating in a disaster exercise with your organization? And right now I'm seeing that everybody has. And that is great to see. I'm really glad to hear that. One of the tricks, or one of the maybe tribulations, if you will, that came out of this is, as you all know, these new requirements don't just revolve around hospitals and nursing homes. They revolve around a variety of other healthcare providers, inpatient and outpatient. And so what has happened in some areas of the country is that all of these folks now have this requirement that did not have it before, and they're all reaching out to their local Office of Emergency Management. And in some cases, the local office isn't staffed or prepared to be able to assist all the different providers. And so as such, it's been difficult for some folks to be able to engage the local Office of Emergency Management in an exercise. One thing that I will mention, and it sounds like you've been more successful than maybe others, but I will mention this because I think it is helpful, is that what some healthcare organizations have done is they've reached out to other local OEM, and OEM has not been able to come on site and necessarily participate actively in what we might call the organization's disaster exercise. But what they have done is many of these jurisdictions run their own exercises at least annually. And what can happen is you sometimes can tag on to that exercise. And what I mean by that is an example that I'll make up is a local community may be running a train derailment exercise where there's going to be a hazardous chemical release. And what you could do is if you participate in some of the planning of that exercise, on the day that your community is running that, you at your facility, hospital, nursing home, or whatever might be, you could run a hazardous materials exercise, or maybe even more realistically, a outside air contamination exercise, focusing on how do we seal up our building, how do we shut down HVAC and keep air from coming into the building that's been contaminated, how do we reach out and communicate with our employees not to come in because the air is contaminated, how do we communicate with families, things of that sort. So you're doing something physically at your site, but you're really tying into something more grandiose. So I just offer that if at some point you have some difficulty, maybe some of you are already taking that approach, and if you are, that's great. It's a great way to engage with your community partners. So as I mentioned, a full-scale exercise, in fact, is this kind of boots on the ground concept where we're physically doing something. The tabletop exercise is, again, this kind of group-led discussion by a facilitator, talking through procedures and policies and how they would actually be implemented. So let's talk a little further now about actually developing an exercise. And these items, I believe, are true whether or not it's a full-scale functional exercise or whether it's a tabletop. The same concepts, frankly, generally apply. So there's some key roles. The first role being that you really need to have a facilitator, somebody who's going to own the exercise, who presents the scenario and facilitates with all the different participants. Then identify the players. So it's not usually realistic that the entire organization is going to be able to participate. So who really is going to participate from the organization? What are their roles going to be? And again, who are the players outside of the organization, maybe such as fire, EMS, police, or others? it's always a best practice, if possible, to have an evaluator, somebody who is not involved in the exercise but can observe, take notes, and that information can be particularly helpful as we're putting together an after-action report at the completion of the exercise. And then you may also want to have some other observers. I always find it nice, particularly within a coalition, it might be helpful that you could invite some of your colleagues to come and observe your exercise, and then they'll invite you to observe theirs, and we all get to learn everybody's best practices and see everybody's tools and only do things better thereafter. So I often break down exercises into about 8 steps or so. So first is kind of determining the exercise scope, and then identifying the goal and its specific objectives. And I would offer that in most cases, the goal is that we want to, one, provide education through the exercise to our team members, and two is we want to test our plan, and we want to test our team. And in a backwards way, we're really testing the education of our team and how effective that is. And then the objectives may be very specific, may even be based on your scenario. That we want to test our ability to set up triage, or we want to test our ability to track our patients or our residents through an evacuation process. So whatever particular objective you might have for that exercise. And then focus on developing a scenario. And as I mentioned before, basing that scenario off your HVA makes a lot of sense. Why would we not want to exercise on things that maybe show up on our top 10 within our HVA? It seems to make good sense. Next, identify the players, as I mentioned before. Set up a date, a time, location, and then developing exercise materials. And some groups do this to the nth degree. Some keep them fairly simplistic. There's not a right or a wrong. Somewhat also probably depends on the scope and the size of your organization and the exercise you're going to run. But the concept is that you should develop a situation manual that outlines the scenario, the assumptions, who's playing, and allows the facilitator to take folks through the exercise. You may also develop some injects. And let me give you an example of injects. Sometimes we're in an exercise, we're trying to really test some specific items. So recently in a surge exercise that I was involved in, one of the injects was that the receiving facility, it was receiving patients from another organization, that we had somebody simulate calling the receiving facility and acting as though that they were the media and asking for an update, and in fact asking about a particular patient name. And the goal there was to identify, what does the reception or the operator who gets this call, what do they do with it? And what information do they provide? Is that appropriate? Do they send it to an appropriate area? How do we deal with the media? Things of that sort. So you can use injects like that to really focus on particular things you want to test or observe in an exercise. And then, as I mentioned, we'll conduct the exercise, and then we all have the responsibility afterward of completing an after-action report, which includes an improvement plan, sometimes called an IP. One thing that is helpful is that CMS has provided some tools, and I will show them to you in a few more slides, that you can go to their website and they have a sample after-action report template that can be helpful to you if you don't have a template yourself. There's a number of different templates out there. Again, there's not necessarily a right or wrong, but it's nice that the CMS has in fact actually provided one for you. So when we talk about the exercise elements, again, my opinion would be that there's really kind of 4 components that we always want to include in every exercise. We want to go through that trigger, how do we get into disaster mode? We want to test communications. It's such a big focal point, and frankly, in most exercises, it's usually one of the areas that shows up as an area for improvement. We want to touch on the incident command system. We don't use it a lot, So again, the exercise is an opportunity to become more familiar with that terminology and that process. And then focus on whatever the specific disaster scenario is going to be. So let's talk about those things maybe in a tad more detail. So again, we spoke about this, I believe, in webinar number 2, where we talked about this concept of how you activate. So just like a fire drill, we want to do things somewhat realistically. Activate and commence your disaster exercise the way that you would do in reality. Again, whether it's a page announcement, whatever the communication method is, have employees and staff members doing what they would normally do. Because when you do it, that, as you probably know, that's the best way to remember it. Focus on communications. So I suspect you all have some level of notification tree. And go through those items and maybe make some of those calls. Because you may find that you have a regional director and that person is actually no longer with us. In fact, there's 3 people behind. The phone number doesn't exist anymore. And that's the exact purpose of trying and physically doing some of these things, is to recognize, hey, we need to make some updates or something's out of date or whatever it might be, things that will go into your improvement plan and make your plan better and more accurate as a result of the exercise. Focus on communication. As I mentioned before, it's a CMS focus. It's where we oftentimes have the most breakdown. It's where we have the best lessons learned. Let's be honest, we all generally focus on phone and cell phone. And frankly, it might even be in the reverse order these days, cell phone and then phone. But then let's figure out what are we going to do, and let's practice what we're going to do if those things don't exist at the time of the disaster. And there's really 2 pieces to that. There's one, how are we going to communicate internally? Might be things such as runners, might be portable radios, it might be email if that's working. And then how are we going to communicate externally? And again, I offer to you to be thinking about how could you use some things such as your website. You know, particularly if your website maybe can be manipulated from somewhere off-site, can your website be used as a tool to provide information, maybe some information to staff on what they should be doing and if or whether or not they should be reporting and where, and then maybe information to families and patients or residents. Same thing with using the media, and probably the most common piece now, although we don't always plan it, being social media. So maybe maybe your plan talks about how you can use social media proactively, and maybe during an exercise you should in fact do that. You could put a post identifying that this is a drill, but today our organization is practicing what we would do in a disaster, and this is one of the mechanisms that we would be employing to communicate with all of the different stakeholders at our organization. So food for thought, and again, sometimes it's great to put in writing what we're going to do, but oftentimes it makes even more sense to practice it, and that's through the exercise. It's also a nice opportunity to address some particular procedures that really are applicable maybe to any potential disaster. One, as I mentioned before, is with all the things going on in terms of, unfortunately, violence in our buildings or sometimes outside of our buildings, I would assume that you all have some sort of lockdown procedure. And so in an exercise, what better time to maybe practice how realistically can we go through that procedure? Does the procedure work? How long does it take? Where are the faults? What do we need to update? Maybe it's a 2-phased approach. Maybe in the first part of your exercise you want to lock down a particular building, but then in the second part of your exercise you want to talk about how you would lock down your campus or your grounds. So again, a real good opportunity in the exercise to do those types of things. You all have I'm sure, some level of procedures that are focused on managing staff. We manage patients and we manage staff. And in the managing staff, there's a number of pieces in there. And Florida is best known for recognizing that, hey, in certain disasters, we know to be able to get a staff member to come to the facility to provide patient care, we are going to have to help them take care of their families, because family comes first in almost all of our situations. So as such, how are we going to provide sheltering for families? How are we going to provide food for families? Maybe even in some cases, how are we going to address family pets? Because if you have a pet, you know that a pet is family. So those might be some of the things that in an exercise at some point you want to either review or maybe even set up and enact and see the reality of how you would engage some of those items in a true disaster. As I mentioned before, incident command is a real important part of emergency preparedness. I like to think the hospitals are a little bit more spoken in it than I think a lot of the other healthcare organizations are. Use it in your exercises. If you use it in your exercise, then there's a much better chance than we'll be familiar with it in reality at the time of the disaster. And put people into roles. Oftentimes, probably the majority of disasters that you have to deal with, there's really only one position that has to be implemented, and that's the incident commander. But in your exercises, or at least one of them, make it a bigger situation. Engage some of the other sections. Engage support personnel, such as the public information officer or a document recorder, so that you can practice those things, and so you can use the various different tools. You can use the job action sheets. You can use some of the forms that are provided as part of the incident command system. There's prescripted messages and a whole litany of tools that, again, you don't want to suddenly start to become familiar with at the time of a disaster. ICS is great for training, and then it's great to make sure you're utilizing it to some degree in your exercise. And then the final piece is, choose a particular scenario and use that scenario as part of your exercise. And I have a list here over a few different slides of some of the types of disasters that you may have that rank high on your HVA. One that I wanted to mention specifically and share some thoughts on was active shooter. So I know at RPA we get a number of requests to provide active shooter drills or exercises. And we oftentimes, in most cases, don't recommend that that's the way to go. What we do recommend is that every organization should have an active shooter procedure. That procedure certainly should be developed in collaboration with local law enforcement. And we think that training, generally speaking, unit-to-unit or unit-specific training is the best way to approach education from dealing with active shooter. Really focusing on, in a particular area, what safe rooms are available that can be locked, what rooms have phones in them, what equipment could be used to secure doors that can't be locked right in the area, things of that sort. The problem with active shooter exercises is that sometimes they can go a little bit over the top. And I'll give you an example of that. So a couple of years ago, a nursing home out in the Midwest made headlines when they were trying to do the right thing. They were reaching out to local law enforcement, and they wanted to run an active shooter drill. And law enforcement had a particular police officer who was responsible for that and was very eager to engage with them. And so this particular officer and the administrator met once or twice and determined that they were going to run an active shooter drill. And what came out of that was on the day of this drill, it was not announced to the employees. In addition, the officer who was assisting came to the facility. He was in normal clothes. He was not in his uniform. And he utilized a fake weapon and simulated taking a hostage. But of course, the staff member was not aware that this was an exercise. And so I suspect right now those that are listening are all shaking their heads being, oh my goodness, what a poor process. And I can assure you that there were a number of lawsuits that came out of it. But at the end of the day, the active shooter piece is really one about education. It's not so much about running the drill, having fake weapons or having real weapons. I know in some hospitals I've seen they bring in the SWAT team, and even if they announce it to everybody, it just doesn't really put people in a good, feel-good scenario, particularly if you're a patient or a resident. So it's a little bit of our opinion. I offer that to you. Have a plan, certainly educate, but be cautious about how you might engage if you decide to do some sort of exercise or drill regarding active shooter. On this next slide, I just put a couple stars next to missing residents. So for those of you that are nursing homes on the call, CMS very specifically called out that long-term care facilities need to have robust procedures for missing resident and for elopement. I suspect it's probably high on your HVA anyway, but if for any reason it wasn't, you need to have a robust plan, and I would suggest that that be something that you do exercise occasionally. And then finally, a great exercise is always loss of central services. Sometimes that's even a great tabletop exercise. What are we going to do if we lose generator, if we lose emergency power, if we lose heat, or more important in Florida, if we lose the ability to cool? So talking through and reviewing those procedures, and those aren't just procedures, but they're also probably vendor agreements and relationships that you have. And again, calling those vendors and ensuring those relationships are still strong during an exercise. So again, as you pick a scenario, review the HVA, engage with local emergency management. Maybe they have something you can tie into, or maybe they have some suggestions for something they would like to participate in with you. Although they're not really specific disasters to themselves, the concept of evacuation procedures and or surge and influx procedures really can be complex and test a lot of different things. So maybe consider those or components of those in your exercising as you plan exercises in the future. And again, as a reminder, this whole process is about developing plans, training staff, running exercises, determining where we need to improve, where we need to update our plans, and doing so and going through the whole thing again. And the onus is on you as the provider to document all those different areas and all those different actions that are being taken. As I mentioned to you before, if you go to this link, and this handout, the handout for these slides is available. If you go down to the bottom right corner where the file folder is, you can download this handout along with a sample compliance calendar that we have included for you. But you can go to this link and it will take you to the CMS website where you can then pull up their sample after action report template. And this is just a quick cutout of what that template includes. It's fairly simplistic. It's not over the top. You may or may not decide to include the appendices, but it would help you if you want to be able to put together something that meets the requirements for an after-action report, but isn't really over the top difficult or kind of crazy documentation. So the last item that I wanted to mention was to talk a little bit about what we've learned in kind of this short 4 to 5 months where CMS and state survey agencies have been surveying to these new emergency preparedness requirements. And so this is a fairly recent listing. There's finally some data available, and this is a listing that I pulled out of the top 10 e-tags that have been cited in the first few months. And we've already talked at length about 2 of them. the emergency preparation and testing requirements. So surveyors are going in, they're asking those questions that we talked about previously, and often some facilities are not prepared or don't have the documentation, and they're getting an E39 tag. Or they haven't, pardon me, that's for the testing, an E37 tag, or they haven't done and documented exercises appropriately, and that's where they're receiving an E39 tag. I'll mention briefly what some of these other tags are. And I think the first one, E35, is particularly important. This one applies particularly to long-term care. So, and this is new, and therefore I understand why a lot of folks aren't doing it. They didn't know about it. But one of the new requirements is that the long-term care organization, or the IID, has a responsibility now to provide some level of education to residents and resident families. Now, the final rule doesn't tell you what you have to provide, nor does it tell you how you need to provide it. So what we're seeing some organizations do is some organizations are putting together some information as part of an admissions packet that might say, hey, when we have a disaster, here's generally what we do at our facility, here's how we communicate with you, here's what you can expect. You might also want to check our website or social media, whatever it might be. And they're including that as part of the admissions packet. I've seen some other organizations that are doing sometimes quarterly or biannual newsletters. And as such, they're including a section on emergency preparedness. And that's their mechanism with sharing some information with residents and families. So again, how you do it, frankly, is up to you. But you need to somehow do it, and you need to be able to show upon survey what your process is for doing that. And it's totally new, and it doesn't shock me at all that E35 is number 1 on the list. The next item, E1, that pretty much means that a surveyor walked into a facility and they didn't have much of an emergency preparedness program at all. I'm kind of surprised to see that as number 2. I would be very surprised to see that high in Florida. This is a national stat that I have here, but that's what that's referring to. E24 talks mostly about volunteers. And in my opinion, the reason this keeps popping up is because you may, as part of your emergency preparedness program, have a section on volunteers. And if you do, that's great. But in many cases, and I know in our guides that we developed, volunteers are spattered throughout a number of different areas. Volunteers are addressed under managing staff, because we do the same thing for volunteers that we do for staff. Volunteers are addressed very specifically in the credentialing plan, if we need to credential volunteers at the time of a disaster. Volunteers may be addressed in your incident command system. One of the roles of the planning section chief is to manage volunteers, and I know Hicks and Nix both have a volunteer accountability form to be completed. So what I would offer is, if you don't have a very specific volunteer section, just make sure you know where volunteers are addressed in your plan, so that when you're asked and a surveyor is looking to check off some boxes, you can very easily take them to the 1, 2, or 3 areas where volunteers are addressed. E26 seems to be one of great confusion amongst both providers and amongst surveyors. I've had a number of surveyors that I know I've engaged with who are trying to figure out themselves exactly what they should be looking for here. I hope that maybe you've heard of an 1135 waiver, and that's what's referenced in E26. And the concept here is that during a significant disaster or a regional disaster, if the president declares a disaster and if the Secretary of HHS declares a disaster, then 1135 waivers may be granted. And they may be granted to do certain things, such as allow you to exceed licensed beds, for a particular time, because the fact is you had to influx your population to accommodate for somebody else that had to evacuate. Or it may loosen credentialing requirements for a period of time for care providers. But you really yourself can't just request an 1135 waiver, and that's where there's some confusion. Those other pretty significant items have to happen first, and then you would be working with your local authority having jurisdiction to see how they might apply to you. Within that concept of 1135 waiver, also talks a little bit about alternate care sites. And so I do suggest that you be thinking and have an arrangement with an alternate care site nearby. So, you know, most disasters really allow you some time to react. But occasionally there's a disaster where you just have to move quickly. And in those cases, that's where we might have to set up an alternate care site, potentially maybe at a school or a gymnasium or a fire hall or some place where we can triage and manage patient and resident care until we can get something a little bit more organized and formal in play. So that is something else that is referenced under the 1135 waiver and E26. E9, we have talked about many times. Again, the onus is on you to be reaching out to your local, regional, state partners and to show collaboration and to document collaboration. E18 is all about tracking, the tracking of patients, residents, and staff. So ensuring that you have a mechanism as part of your plan to do that. Some places have electronic mechanisms. Some places use paper tracking form and they pin it to the back of the patient. There's not a right or a wrong, although if you have something high-tech, it's always good to be able to fall back on something that's paper in case the high-tech doesn't work. Communication planning is a big part of the CMS requirement, and so they're looking very thoroughly to make sure you have a robust section on who we're talking to, how we're talking to them, backup plans, things of that sort. Policies and procedures. So again, surveyors are looking to make sure that you have completed your HVA and that the items that are on your HVA that pose a significant risk to you, that you in fact have procedures to address them. The onus is also on you, and this is particularly true in Florida, to do your own assessment of how much food, how much water, how much generator fuel you will need to be able to sustain a disaster. At least 72 hours, in your case maybe 96 in Florida, or whatever your HVA says to you that you really need to be doing. So that onus is on you to review it and then potentially take actions to mitigate it. So you may determine, hey, you know, we really actually don't have enough pharmaceuticals on site to be able to go for even 2 days. So as such, let's put a plan together, part of the improvement plan, and let's figure out how we're going to address that situation. And then last but not least on here is E31. I would like to think that all of you hopefully have emergency contact information as part of your communications plan. That's a pretty easy checkbox to have. Who do we call and how do we get a hold of them? So as I mentioned before, as we kind of wrap up, the EPP program now is just that. It's a program. It includes all the components of doing the risk assessment, all hazards planning, having effective policies and procedures, the training exercise, and the whole 9 yards. And we're hopeful that these 4 webinars have helped provide some guidance to you on how to put that program together and how to maintain best practice moving forward. So, as always, a couple closing things, and I'll take a peek. It looks like there is at least one question up here. I want to remind you that the handouts for this presentation are available to you to download if you go to the bottom right corner with the file folder. In addition to that, we included a compliance calendar. It's a sample compliance calendar that you can download. You can use it as you wish, but it might help your organization put together an annual calendar of all the different things that need to happen to ensure that you're in compliance at the end of the year. So let me hit one question here that I see. Can an actual disaster event replace an exercise? That is an excellent question, and I'm glad you asked it. The answer is yes. So if you have an actual event, and if that event in fact requires boots on the ground, you're physically doing things, and it engages other community partners, law enforcement, fire, emergency management, as long as you write up that situation with an after-action report and an improvement plan, then yes, that could count. If it's an internal disaster, maybe you didn't involve the other partners, but you had to deal with something internally, maybe the loss of a utility or something of that sort, then you still, as long as you write it up with a formal after-action report, yes, you in fact can use that as one of your 2 disasters. In that case, you would still be required to run a full-scale community-involved exercise to make up your second exercise. So we're just about at the top of the hour. That's the only question that I had. So as we finish up, I just want to say thank you for allowing us to speak with this group on 4 different occasions. Certainly, if you have any questions, you can always reach out to us. We're happy to assist, and we've really enjoyed putting these presentations together and working with you. Reach out if you have any questions, and otherwise, have a great day. Thanks so much.